Good evening. Today we are going to talk about hypoxemic respiratory failure. I want to talk about there are three kinds of hypoxemic respiratory failure. So in hypoxemic respiratory failure where the lungs cannot adequately oxygenate the blood leading to low arterial oxygen levels. It can be classified into mild, moderate, and severe based on the severity of hypoxemia. It typically measured by PF ratio, which is arterial oxygen content, and the FiO2 ratio. The mild hypoxemic respiratory failure defined and the PF ratio is between 200 to 300 millimeter of mercury. Normal is more than 300 millimeter of mercury. During these patients, the arterial oxygen saturation or content would be 60 to 79 in room air. Clinical features, usually they will have a mild shortness of breath, oxygen saturation typically ranging between 90 to 94 in room air. They may not require supplemental oxygen or they may need only low flow oxygen. The important causes of mild hypoxemic respiratory failures are early stages of pneumonia, mild pulmonary edema, mild acute asthma, or COPD exacerbation. Moderate hypoxemic respiratory failure is defined as PF ratio 100 to 200 millimeter of mercury. Arterial oxygen content in those patients should be 40 to 59 millimeter of mercury. The clinical features in moderate hypoxemic respiratory failure increase workup breathing, tachypnea, use of accessory muscle, saturation typically 85 to 89 on room air. They require supplemental oxygen, sometimes nasal cannula or a mask. The causes of moderate hypoxemic respiratory failure, moderate pneumonia, acute respiratory distress syndrome or ARDS, pulmonary embolism, worsening heart failure. Severe hypoxemic respiratory failure defined when the PF ratio is less than 100. PaO2 in those patients should be less than 40. When you say PaO2, it has to be arterial oxygen content. The clinical features, they will have tachypnea, cyanosis, altered mental status, oxygen saturations typically less than 85 on room air. They require high flow oxygen, NIV, CPAP, BiPAP, or invasive mechanical ventilation. The causes are severe respiratory distress syndrome, severe pneumonia, massive pulmonary embolism, end stages of COPD or interstitial lung disease. Let's check what are the causes of hypoxemia. The basics are very important. The evolving treatment and understanding of the disease is based on the basics. So understanding basics is very important. The causes of hypoxemia fall into 6 different categories. 1, hyperventilation. Number 2, ventilation perfusion mismatch. Third, shunt. Fourth, diffusion impairment. Fifth, low inspired oxygen or low FiO2. And 6, anemia or hemoglobin dysfunction. In hypoventilation, there is a reduced alveolar ventilations lead to inadequate oxygen exchange. That happens when there is overdose with sedatives or opioid. It's also seen in patients with neuromuscular disorders like myasthenia gravis and ALS. Chest wall abnormalities can cause hypoventilations like kyphoscoliosis. Obesity hypoventilation syndrome can cause hypoventilation. The most important is ventilation perfusion mismatch. It's very important to understand what VQ mismatch is. When there is an imbalance between airflow, that is ventilation, and blood flow, that perfusion in the lungs. I will show you in a diagram to explain much better. The causes of VQ mismatch: chronic obstructive pulmonary disease, asthma, pulmonary embolism, pneumonia, and acute respiratory distress syndrome. I want to show you this picture. Normally, the air goes into the alveoli. The oxygen, it carries oxygen, and that diffuses into the pulmonary capillary blood. So there's deoxygenated blood that comes in, get oxygenated, then it returns to the heart. That is normal work of alveoli and capillary interaction. When the airflow is obstructed, as in this case, the deoxygenated blood never get oxygenated. This is called shunt. That means it is shunting from the ventilation. The deoxygenated blood never get oxygenated and goes back to the heart. The obstruction may not be complete. So there is a reduced ventilation. Even though the ventilation happens, the oxygen diffusion is not happened well. As a result, the deoxygenated blood is not completely oxygenated. So more deoxygenated blood being carried to the heart. The same thing can happen in the blood flow area too. When there is a reduced perfusion, meaning when there is a pulmonary vasoconstriction for any cause, ventilation is good, but the perfusion is not that good. As a result, the oxygenation doesn't happen. There is an important thing I need to emphasize. The carbon dioxide diffuses much faster than oxygen diffuses into the capillary blood. As a result, hypoxemia occurs even before hypercapnia occurs when there is a reduced perfusion. Another category is dead space ventilation.
ஒன்றும் பண்ண வேண்டாம். 200க்குலாம் ஒன்றும் பண்ண வேண்டாம்.
The dead space ventilation, where there is perfusion is completely obstructed. As a result, even though the alveolar ventilation is happening, there is no perfusion happening. So this particular capillary will not carry the deoxygenated blood into the heart, but other capillaries do. As a result, the deoxygenated blood will diverted and got more deoxygenation happens into the overall bloodstream. This is called VQ mismatch. This is the most common cause of hypoxemia in most of the diseases we come across. Then true shunt. The true shunt can be intrapulmonary shunt or intracardiac shunt. The blood bypasses the lung without being oxygenated. The extremes of VQ mismatch can cause intrapulmonary shunt. Let's look at this picture. First, intracardiac shunt. The intracardiac shunt can happen most commonly either atrial level or ventricular level. You have to remember, because there is a defect in the atrial or ventricular level, the shunt typically happens from left to right. The reason being, the left side of the heart is high pressure system. Left side of the heart is high pressure system. So the flow happens from left to right. So oxygenated blood goes into the deoxygenated chambers. That doesn't make any big difference as far as oxygenation goes. On the other hand, if the reversal happens, meaning right to left shift happens, that happens in either atrial level or ventricular level, that causes deoxygenated blood being pumped into the systemic circulation that causes hypoxemia. When does that happen? When the right ventricular pressure is higher than the left ventricular pressures. That happens when there is a pulmonary artery pressure high. That happens in pulmonary obstruction or pulmonary hypertension. As a result, the right ventricular pressures are higher than the left ventricle. So the flow happens from right ventricle to the left ventricle. So the blue blood goes into the red blood. It mixes, causes hypoxemia. This is called intracardiac shunt. What is intrapulmonary shunt? We already mentioned the extremes of VQ mismatch causes intrapulmonary shunts. So ventilated alveoli oxygenates the capillaries. The poorly ventilated are completely non-ventilated alveoli. There is no oxygenation happened. The admixture of Deoxygenated blood with oxygenated blood causes hypoxemia. That is the most common cause in most of the pulmonary disorders. The another one is diffusion impairment. That means the alveolar capillary membrane is so thickened, the diffusion of oxygen into the capillary doesn't happen, as it happens in interstitial lung disease and pulmonary edema. As I mentioned earlier, the carbon dioxide diffuses much faster than the oxygenation. So hypoxemia happens in the absence of hypercapnia. It's very important to remember. And other reason is low inspired oxygen. The oxygen content in the atmosphere itself is lower, either because of the high altitude. When you go high altitude, FiO2 is low. That can cause hypoxemia. And also suffocation or inhalation of toxic gases that displaces the atmospheric FiO2. As a result, you will have a hypoxemia. Finally, anemia or hemoglobin dysfunction. Hemoglobin is the one carrying oxygen to the tissues. When there is inadequate hemoglobin, that happens in severe anemia, or it is unable to carry the oxygenation, as it happens in carbon monoxide poisoning or methemoglobinemia, can cause decreased oxygen carrying to the tissues. So what are the impact of hypoxemic respiratory failure? Severe RDS associated with increased ventilatory days, length of stay, and mortality as high as 52%. It used to be 60%. Now in advanced countries, it has come down to 30%. Still, it is very high. That means 1/3 of the patients come with ARDS do not go back home. Many patients with mild RDS go unrecognized, so fail to receive appropriate lung protective ventilations. The recognition of ARDS is very important. And ventilator-induced lung injury understanding is very important because it can perpetuate the lung damage. So what are the high-risk conditions for the hypoxemic respiratory failure? Sepsis, pneumonia, and aspiration. There are few things we can do to prevent the occurrence of hypoxemic respiratory failure. In other words, acute respiratory distress syndrome. Restrictive blood transfusions. When I say blood transfusion, red blood transfusions also can cause transfusion-related acute lung injury. But the platelet and fresh frozen plasma have a higher association than pure RBC or PRBCs. So keep that in mind. And appropriate and timely antimicrobial agents when you treat sepsis and pneumonia. Early antimicrobial agent therapy is very important to reduce or prevent or mitigate the occurrence of ARDS. Diligent perioperative care. The trauma is associated with ARDS or hypoxemic respiratory failure. Proper diligent perioperative care that includes fluid load during the surgery and also usage of sedative medication that can cause hypotension, and the extensive trauma and lung protective ventilation after the surgery that plays an important role. And always adherence to the lung protective ventilation, because we perpetuate lung injury by doing either high tidal volume or doing non-protective ventilation. We'll go into the details further. Aspiration precautions. Aspiration accounts for 30% of ARDS. When that happens, mortality is high. That means that leads to the severe ARDS. And appropriate management of shock. Hemodynamics is very important. Maintaining hemodynamics, improving perfusion is very important. And pancreatitis and trauma management very important. There's also another concept called patient self-inflicted lung injury. The high respiratory drive in most of these diseases causes large tidal volumes. They tend to breathe fast. As a result, they take lots of big tidal volume that can cause injury to the alveolar capillary membrane. It can also happen with pressure control ventilation, pressure support ventilation, APRV, and NIV. All of them can cause self-inflicted lung injury. That means you need to, whenever you put, whether the patient breathe themselves or you put the patient on non-invasive or invasive ventilations, watch the tidal volume. In patients with moderate and severe ARDS, consider sedation and paralysis. So, how to diagnose? Blood gas is important. Saturation monitoring is important. X-ray needs to be done. CT scan sometimes needed. Pulmonary function test and echocardiography needs to be done in appropriate circumstances. So, how do you treat? The first is low flow oxygen delivery system. When the saturation is little low, you can manage with nasal cannula. You can go from 1 to 6 liters per minute. Simple fast face mask that can deliver 5 to 10 liters per minute. There are high flow oxygen delivery systems available one should use, especially when you want to give precise FiO2 delivery. You can use Venturi mask. Of late, the high flow nasal cannula have been used in a significant increased percentage than any other modalities. The advantage of high flow nasal cannula is delivers heated humidified oxygen. You can titrate flow rate and the FiO2 independently. It has lots of advantages. It is gentle to the alveoli and it helps with inspiratory flows necessary for the patient. And it causes a little bit of PEEP, but not overly injurious to the alveoli, and it is well tolerated, and also it causes dead space washout. I have a separate video on high flow nasal cannula. If you are interested in, please listen to that one. A non-rebreather mask, it gives the highest FiO2 for severe hypoxemia. In Venturi and high flow nasal cannula, you can go all the way up to 100%. Mechanical ventilation, it has two categories, non-invasive and invasive. This non-invasive ventilation is delivered via mask. The indication are COPD exacerbation, cardiogenic pulmonary edema, and mild acute respiratory distress syndrome. The contraindications are when there is a severe respiratory acidosis, altered mental status, or inability to protect airway. In those conditions, do not use non-invasive ventilation. Straight away go for invasive ventilation. Even though non-invasive ventilation is a good therapeutic measures in patients with hypoxemic respiratory failure, overly waiting for invasive ventilations or delaying invasive ventilation increases mortality. So it's a great tool, but you have to keep in mind, are we delaying the eventual invasive ventilation? And in other words, when to intubate. I have a couple of slides on it, but keep that in mind. Non-invasive is a great thing to start, but it does fail at one point. In vast majority of the patients, it does work beautifully well. This is a slide from last year. This is, of course, in pediatric ICU admissions. As you can see, the high flow nasal cannula being used really exponentially for the past 10 years. Of course, this data is from United States. And so does non-invasive ventilation using mask, but high flow overwhelms and other other 5 modalities, and now second being non-invasive and invasive mechanical ventilation have not gone up significantly, but high flow. So knowing all about high flow is very important, and also other non-invasive modalities. I have a separate video on high flow nasal cannula and non-invasive, planning to do ram cannula sometime next week. So the question is, When should we intubate in hypoxemic respiratory failure? There is a beautiful article published in 2023 NEJM Evidence. According to them, we do not have a clear-cut indications for, well, clear-cut guidelines for when to intubate, but there are some guidelines, and let's look at that one. There are respiratory criteria one can use when to intubate. My personal opinions goes with that one. When there is a hemodynamic failure, meaning the patient need vasopressors, a patient in respiratory distress, I will go ahead and intubate those patients. I will not work with the NIV because the chances of failure is high. As this article shows, hemodynamic failure or sustained hypoxemia despite high flow nasal cannula or NIV. This is very important. Optimized high flow nasal cannula. Most of the circumstances I have come across, the high flow nasal cannula NIV is not done properly. As a result, the failure happens. But you need to use high flow nasal cannula NIV appropriately so that we can say, yes, high flow nasal cannula did not work at NIV. When you do optimize high flow nasal cannula or NIV, when the hypoxemia persists, or where FiO2 requirement is more than 80% or saturation is not coming up or less than 90, those patients intubation is a rule. Or failure to improve after 4 hours of high flow nasal cannula NIV, there is hypoxemia, tachypnea. These patients need to be intubated. So delaying invasive ventilation increases the mortality. So what are the ventilator strategies you will use after intubation? One should remember ventilator-induced lung injury and prevention is the most important in the management of hypoxemic respiratory failure. Number one, tidal volume should be 4 to 8 ml per kilo. The most important, what is the parameter you go by? Keep the plateau pressure less than 30. See if the plateau pressure is more than 30, reduce the tidal volume. The high tidal volume is an important determinant of the development of ARDS or worsening ARDS. Another important parameter or variable identified 2015 and later is called driving pressure. What is driving pressure? The difference between plateau pressure and the PEEP. It has to be below 15. It is single variable that determines the mortality in patients with ARDS, the driving pressures. Keep the driving pressures less than 15. This article published in 2015, as you can see, the mortality goes high when the driving pressure is more than 15. So whatever you do, either titrating up on the PEEP or titrating the tidal volume, make sure driving pressure is below 15. The other parameter very important in hypoxemia is PEEP, positive end expiratory pressure. Optimizing PEEP is the first consideration in patients with refractory hypoxemia because the PEEP inflate the alveoli. The distended alveoli promotes alveolar ventilation, thus improves oxygenation. There is a conflicting data about the mortality in both high and low PEEP. There is a beneficial effect appeared with severe ARDS patient, and afterwards the data is conflicting, as I mentioned earlier. So at this point, in mild ARDS patient, the high PEEP did not benefit. So what is mild ARDS as we designed? When the PF ratio is between 200 to 300. In moderate to severe ARDS, the high PEEP seems to help the mortality or improve the mortality. How long one should wait once you titrate the PEEP up? It takes at least 5 minutes Sometimes it may take up to 60 minutes or longer. So you have to wait after you move up on the PEEP. So Gattinoni came up with a recommendation for PEEP according to the ARDS severity. In mild ARDS, that means the PF ratio between 200 to 300, start with 5 to 10. Moderate ARDS, the PF ratio is less than 200, like 100 to 200, 10 to 15. Severe ARDS, the PF ratio is less than 100, start with 15 to 20. There are some advanced methods to identify exact PEEP needed in those patients, like stress index, esophageal manometry, ultrasonography, electrical impedance tomography, but it's not available in every center. So, in a resource limited setting, in most of the settings, this is the best go to. And the other important things when you titrate the PEEP, check the driving pressure. As you increase the PEEP, the driving pressure should decrease because as you open up the collapsed alveoli, the driving pressure should come down. On the other hand, when you titrate up the PEEP, if the plateau pressure goes up or driving pressure is up, that means the alveoli is already over distended. So going further up on the PEEP is not helpful for the patient. The other maneuver we do, what we were doing, routinely called recruitment maneuvers. What is a recruitment maneuver? It's a transient increase in transpulmonary pressure to promote reopening of collapsed alveoli, thereby improving gas exchange and the distribution of volume in the lungs. There are two ways we do recruitment maneuvers. Sustained high pressure inflation using pressures 30 to 40 centimeter for 30 to 40 seconds. Most of the time they do 40 centimeter for 40 seconds. Second is stepwise increase in PEEP with a constant driving pressure, that means 15 centimeter or fixed tidal volume 4 to 8 ml per kilo. But most of the centers in United States, there is an IPV machine. It does automatically done. But the studies done, recruitment maneuvers, does it help in, does it have a mortality benefit? So far, no studies have shown that recruitment maneuvers has a mortality benefit. But does it increases the oxygenation? Yes, it does improve the oxygenation. The mortality benefit from recruitment maneuvers still debatable. Other non-conventional ventilator modes. Most of the ventilatory modes have been used, appreciated initially, then fell out of favor later on. But it is worth a mention, and these are the tools one should have in hand in extreme cases. Number one, high frequency oscillatory ventilation still being used in neonatology and also in children. And high frequency percussive ventilations I never used personally, and airway pressure release ventilations often used by surgeons. I have used in multiple times. What do? They improve the oxygenation, but improving gas exchange have not shown any improved survival rate in those patients. Multiple studies have been done. The most notable one is Oscillate trial, have not shown any mortality benefit. In fact, in moderate ARDS, they are harmful. The ARDSNet trial showed some interesting fact. The low tidal volume group in ARDSNet trial have a better survival. That means even though they had a worse gas exchange because they have low tidal volume. So oxygenation may be a flawed surrogate for outcome. It's an important thing, even though the ARDSNet trial published in 2004 or early 2000, still that is true. But afterwards, we tried APRV, high frequency, so on and so forth, but we have not shown any mortality benefit. What is high frequency oscillatory ventilation? Wherein the tidal volume is very small, 1 to 2 ml per kilo. The assumption is it is very gentle to the lung. They often have a high MAP. So distended alveoli, very gentle, very small tidal volume. As a result, it is very gentle to the lung, but it is delivered in very high frequencies. There are randomized control trials showed no survival benefit. So as a result, the latest recommendations, high-frequency oscillatory ventilation should not be used routinely in moderate or severe ARDS. In fact, it is harmful in patients with moderate ARDS. But can be considered in those patients with ARDS where conventional means fail and when approaches such as prone ventilation and ECMO are either contraindicated or unavailable. So learning and having that tool will be helpful in some patients. High frequency percussive ventilation. It is pneumatically powered, pressure limited, time cycle, flow interrupted breaths with biphasic percussions. It generates mini bursts or pulses of subtidal volume, resulting in the production of intrapulmonary percussive waves. Percussive breaths are purported to facilitate the clearance of secretions, facilitate lung recruitment, reduce the need for sedation. With the oscillatory ventilation, it has improved the oxygenation but has not shown any survival benefit. Finally, airway pressure release ventilation. It uses two levels of airway pressure. It improves the mean airway pressure, thus opens up the alveoli and improves oxygenation. It has been even shown it improves the cardiac output and it allows the patients to breathe spontaneously throughout both the cycles. But the latest randomized control trials have not shown any survival benefit with APRV. So at this point, the recent guidelines have not supported any of those non-conventional modes. So what about non-ventilatory strategies like neuromuscular blockade? It's frequently used in management of patients with ARDS who have severe hypoxemia. The lung safe study showed neuromuscular blocking agent was used in about 22% of the patients, including about 38% of the patients with PF ratio less than 100 millimeter of mercury. The common indications, they used neuromuscular blockade when there is a poor ventilatory synchrony with deep sedation. So don't use neuromuscular blockade without deep sedation. It's very important. That's the most common use. The routine use of neuromuscular blocking agents have not shown any survival benefit. So at this point, the ACCM has a weak recommendation to use neuromuscular blocking agents. If you have to use in severe hypoxemic respiratory failure, use cis-atracurium and use yearly. That means in the first 48 hours. First at 48 hours and cis-atracurium. Why cis-atracurium? Number one, the hepatic clearance is not needed. Number two, it has some anti-inflammatory effects apart from giving neuromuscular blocking effect. The prone positioning have been used for the past 2 decades. Initially, we used it. It does improve the oxygenation, so fell out of favor. The reason being the high incidence of extubation and the initial trials were not that promising. It came back, but you have to use in specific circumstances in specific way. Okay, what is the rationale for prone positioning? It gives a more homogeneous pleural pressure. Dorsal lung is better perfused and aerated, thereby decreasing intrapulmonary shunting. Intrapulmonary shunting is a very important part of hypoxemia in patients with ARDS. It improves ventilation perfusion matching, improve lung recruitment, less ventilatory-induced lung injury, and decreased release of pro-inflammatory cytokines, improved PaO2 and decreased PaCO2 and plateau pressure by recruitment, which helps to preserve the pulmonary circulation, improve the right ventricular dysfunction. These are the rationale for doing prone positioning. Following several negative RCTs, as I told you, we did use, then fell out of favor, and the Gorin et al. Reported benefit with prone positioning in severe ARDS in multi-center randomized control trial. They showed the 16% absolute risk reduction and 51% relative risk reduction with the number needed to treat 6. For benefit to occur, you need to treat 6 patients. In that particular randomized control trial, the PF ratio was less than 150 if I were to more than 0.6 and PEEP more than 5 were enrolled. The most important thing to consider is adequate PEEP titration needs to be done before prone ventilation. As I mentioned earlier, the PEEP titration needs to be done by looking at the driving pressure. As long as the driving pressure goes down, that means alveoli is opening. When the driving pressure goes up, that means we are already over-distended. Back off on the PEEP. These are certain considerations when you use prone positioning during hypoxemic respiratory failure. Early application of prone positioning when severe hypoxemia persists after initial stabilization. The duration of prone positioning more than 12 hours per day is recommended. Strict adherence when you do, even though you do a prone ventilation, strict adherence to lung protective ventilation. That means tidal volume in the lower level 48 and plateau pressures less than 30. Judicious use of neuromuscular blocking agents and sedation. It's very much needed when you are prone them for 12 hours or more. And you got to have an experienced, specially trained medical staff while you are doing prone positioning, because extubation is a real danger when you do prone positioning. And optimization of PEEP needs to be done, and discontinuation of prone positioning when oxygenation, that means PF ratio is more than 150, when the PEEP is less than 10 and FiO2 to less than 0.6, at least 4 hours on supine position, then prone position can be discontinued. So these are all the certain things you need to do when you do prone positioning. There is a block, the what is it called? Endotracheal tube blocker that kind of helps to stabilize the endotracheal tube. With that blocker, you can use the prone position much more safer than just taping. Taping can, because when you prone them, they tend to salivate and causes maceration around that loosens the endotracheal tube, thus it dislodges. So potential complications: endotracheal obstruction and dislodgement, pressure ulcers in the dependent areas such as face, chest, and knees. So nursing care is very, very important. There are absolute contraindications to prone ventilations: spinal instability, unmonitored or elevated ICP. Relative contraindication: open abdomen, late pregnancy, severe hemodynamic instability, unstable fractures, and the absolute need for vascular access. These are all certain contraindications to use prone positioning. Finally, extracorporeal membrane oxygenation, otherwise called ECMO. It plays an important role in the management of severe hypoxemic respiratory failure. In severe hypoxemic respiratory failure, we use VV ECMO. That means single dual lumen catheter inserted through the internal jugular vein. That is the data showing ARDS transferred to single ECMO center shows improvement of mortality from 47 to 63% and 6 months disability-free survival. So there is a significant benefit in the early transfer of severe hypoxemic respiratory failure to the ECMO center. So what are the indications for ECMO? When there is a profound hypoxemia, that means PF ratio less than 80, on invasive ventilation with appropriate tidal volume and PEEP. Or when there is a severe uncompensated hypercapnia with a pH of less than 7.15 despite appropriate ventilation for 3 to 6 hours. The contraindication for ECMO, mechanical ventilation more than 7 days, when there is a CNS catastrophe such as stroke, bleeding. Stroke means massive, irreversible condition in an individual who is not a lung transplant candidate. Absolute contraindication for anticoagulation, multi-organ failure, and age more than 70 years. But there are adverse effects with ECMO. They can get infected because there is extra corporeal circulations can get easily infected. And bleeding from surgical site, cannulation site, pulmonary site, GA tract, intracranial. And clotting can happen at oxygenator and circuit, hemolysis, DAC, and oxygenation failure. So you only have to remember when to start, what are the contraindications, and what are the adverse effects one should look forward to. How to approach severe hypoxemic respiratory failure. When the PF ratio is less than 150, even though it's defined as 100, most of the centers use 150 for severe hypoxemia. Tidal volume, make sure it falls in 48 ml per kilo of predicted body weight. Plateau pressure has to be less than 30. Initial PEEP start with, in severe hypoxemia, 10 to 12. Increase the PEEP by 2 to 3 by steps. Stop with hypotension, desaturation, increased driving pressure, or plateau pressure more than 30. Consider recruitment maneuver and decrease PEEP titration based on these parameters. The PF ratio goes above 150, daily attempt to decrease PEEP by 2 to 3 centimeters of water. If there is no improvement, consider non-respiratory causes like PFO, fluid restriction, diuresis. When the PF ratio improved, again, attempt to decrease PEEP 2 to 3 centimeters every day. If it's not improved, consider ECMO at this point. Use neuromuscular blockade. If it improves after 48 hours, decrease or discontinue neuromuscular blockade. Doesn't improve, consider ECMO. The PF ratio still not doing well, consider inhaled vasodilators, consider non-traditional ventilatory modes, as we discussed earlier, especially in those who have contraindications or non-availability of ECMO. So this is how you approach severe hypoxemic respiratory failure. What is the combination of ECMO and prone positioning? There is a limited evidence exists on the combination of ECMO and PEEP. The combination of EV ECMO and PEEP improved both oxygenation and respiratory compliance without any serious adverse events, but we need more data to support to use combination at this point. Miscellaneous therapies. Fluid restriction. The FACT trial looked at aggressive fluid restriction. Does it help in patients with ARDS? Definitely improves the lung function and increase the ventilator and ICU free days, but it's not shown any mortality benefit. The similar results were seen with FACT Light trial. But it has been shown if you do a diuresis or negative balance on day number 4 or 48 hours later, it has associated with improved survival, even though these two trials did not show any mortality benefit. So the recent SCCM guideline for sepsis, they have changed from 60 ml per kilo to 30 ml per kilo. So the fluid management is important key in preventing and mitigating the effects of ARDS. Inhaled vasodilators, again, inhaled vasodilators, there are two kinds, prostaglandins and nitric oxides. They're selective pulmonary vasodilators, improve oxygenation and helps with pulmonary hypertension. As not shown, definitely improves the oxygenation, but it's not shown to improve the mortality. And especially nitric oxide has potential for renal dysfunctions and methemoglobinemia. Prostaglandins can result in hypertension. I have used prostaglandins and nitric oxide, have not. If you use properly, just inhale, prostaglandin usually does not. According to the current guidelines, they should not be used routinely. Inhaled vasodilators might be used as a bridge to other therapies such as ECMO, or if the ECMO is not available or contraindicated. The most important of, along with lung protective ventilation, treatment of the underlying cause is very important, especially in sepsis. Yearly fluid management, vasopressor management, and antibiotic management is key in preventing or reducing the ARDS, thus improving the mortality. Pneumonia, again, yearly initiation of antibiotic is the key. Pulmonary embolism, identifying and treating aggressively and much faster. Cardiogenic pulmonary edema, asthma, interstitial lung disease, all these diseases can cause ARDS that have 30% mortality. Early identifications, treating aggressively will prevent ARDS, thus improve the survival rate. The additional considerations. You have done all lung protective strategies, optimal PEEP, optimal driving pressure, so on and so forth. Still, the patient is hypoxemic. 20% of the severe RDS patient has a pattern for foramen valve. So consider contrast study to rule out persistent PFO. And other important thing is acute or cor pulmonale associated with severe ARDS that is seen in 25% of severe ARDS. So echo is very important to look for PFO and also look for RV dysfunction or increased pulmonary vascular pressures. Most of these patients end up in ECMO that times ARDS severe enough, or you can do maneuver ventilation and fluid therapy and vasodilators to help with carpal thus help with hypoxemia in those patients. Conclusions. In hypoxemic respiratory failure, first categorize whether mild, moderate, severe based on the Berlin criteria, PF ratio 200 to 300, 100 to 200, and less than 100. Prevention, aggressive early treatment of underlying disease is the most important way of preventing and lessening the effect of ARDS. Mild to moderate hypoxemic respiratory failure, oxygen high flow nasal cannula, RAM cannula, and other non-invasive ventilations. Even they are very helpful, but monitor for when to intubate. Do not delay intubation because that increases the mortality in case if they need. But 75 to 80% of the time, this non-invasive ventilation works if it is used appropriately. Severe hypoxemic respiratory failure, low tidal volume, plateau pressure less than 30, driving pressure 15 or below, PEEP titration, NMBA, especially in the first 48 hours, use cis-atracurium and prone ventilation. And yearly refer. If these maneuvers doesn't help, refer to ECMO center because ECMO center's survival rate is 63%. And inhaled vasodilators, non-traditional ventilators most may be considered in those patients who cannot have a contraindication for ECMO or no accessibility. In those patients, definitely vasodilators and non-traditional ventilators will help. This concludes seminar on hypoxemic respiratory failures.